All right. Well, good morning, ladies and gentlemen. I'm Chuck Ramey. I'm the Chief of Public Affairs for the VA Southern Nevada Healthcare System. And to my left is Ms. Cheryl Martin. She's our Associate Nurse Executive for Community Care. Hope I got all that right. She oversees all of our home care programs, our geriatric programs, and all of our, all the community care that we coordinate either with the hospitals or with sending out services to the community. Cheryl and her team of a phenomenal staff that continues to grow. They do a great job for us, so Cheryl oversees that. And she is also our Mission Act champion. Each facility in the VA has a Mission Act champion that is here to kind of help guide our staff members as well as our veterans and stakeholders on what's happening with the Mission Act. And Cheryl has been busy pulling double duty with that, so that's why Cheryl is going to be our briefer today. And obviously, most of you know Dr. Ramu Kamanduri, who is our Chief of Staff here at the VA Southern Nevada Healthcare System. So Dr. Kamanduri, we do appreciate you joining us as well. And Dr. Kamanduri has been working with our clinicians to kind of get them ready for this, because some of the things and the tools that we're going to be using are going to be a little different to determine eligibility for that community care, and some processes need to be put in place, and there's been training, and Dr. Kamanduri has been kind of overseeing that. So let's talk a little bit about the Mission Act. So just to give you all a little bit of background on the Mission Act and kind of how we got here today and where we're going with forward is, you remember back in 2014 we did start the Choice program, and it was kind of haphazardly put together, to be quite honest with you. This was done, they had a program stood up in less than 90 days, and if you've worked with any major insurance companies, trying to put something together in less than 90 days comes with some challenges, and but they did it. They went through those challenges. They stood up the Choice Act. It was a temporary kind of fix at that time to kind of help with wait times and scheduling issues. They kept renewing that Choice Act, but the VA, working with Congress, with your legislative officials, said, hey, we need to be finding a better way to do this. Obviously, community care with the VA is nothing new. A lot of people feel like we didn't start working with the community until 2014, and there's certain individuals and certain groups out there that'll tell you that, but it's not true. The VA has been working with the community to provide community care since day one, so we can't be all things to all veterans all the time, but we try to do as much as we can, but there are times we need our community partners to be part of that. So the Choice Act did kind of formalize some of that, but working with Congress, we said we've got to make this permanent, and we need to have a process and a program in place that does that. So our legislators, working with the VA, put together the Mission Act of 2018, which was signed by President Donald Trump on July 6th of last year, and or excuse me, June 6th of last year. And it goes into effect on June 6th this year. So there were several different things that were kind of provisions with the Mission Act, and the community care part is the big one we're here to talk about today. But several things with this partnership was to make the veterans more of a partnership in their health care. Obviously, we know with the Choice Act and the process and the programs and the way things were set up, it always hasn't been easy for the veterans or their family or their caregivers to coordinate that community care or support, because a lot of times we were, the way the law was written and the way the processes and procedures were written, it was like, okay, VA can't do it, we need to give you a consult, we're going to send it to this third-party provider, in our case, which is TriWest here in the Western United States, and then TriWest is going to work with the veteran or the family member to schedule that appointment, and we know that there's been difficulties and challenges with that, but we feel like with the Mission Act, we'll bring some of that back in-house, and Cheryl's going to talk about that, so it's going to be more of a conversation with you and the VA again. TriWest will kind of still be our third-party provider in this region. There are 6 regions of the country, or across VA, to include when you talk about the Pacific and the Mariana Islands, where they're standing up community care networks. And for at least another year, TriWest will kind of be our community care network here in the western part of the United States and Hawaii, I believe. But there will be a new contract that will go into effect. We're not sure who got that contract. We know it's probably going to be announced here, but TriWest will be our contract of record for the immediate future, but you will no longer have to work with TriWest. It'll be working with the VA to schedule those appointments with the TriWest providers. But I think the big thing is they'll establish a network of providers the VA will coordinate the care with those providers, with the veterans, and that's how that'll work. But a few other things with the Mission Act that kind of came into play that we're still waiting for further guidance on is one. I know a lot of people have been interested in the caregiver support program and what's happening with that, and we're still waiting on legislation, not legislation, but we're still waiting on processes to be put in place. We think sometime in 2020 is kind of when they'll lay out the caregiver support program and expand that service. Because what happened was when they wrote that law for the Mission Act, basically there were some things put in place at that time to actually improve some IT systems, some processes. They have to redetermine eligibility requirements because obviously the caregiver support program as of right now is a post 9/11 veteran program, and it's a recovery-based, like, supposed to be a temporary type program. Obviously, when we open it up, we know that our World War II veterans and our Vietnam and our Korea War veterans may not necessarily, it may not be as much recovery-based as it is sustainment and quality of life. So we're waiting for some more guidance on that, and that'll come out, but right now we're thinking sometime in 2020, once all those processes and procedures are put in place, that the caregiver support program information will come out on that as well. The other thing we're kind of with, I think Cheryl will talk about this a little bit too, is the urgent care benefit. So we're still waiting for some information on who our urgent care provider will be, but there will be an urgent care benefit too, and that's something that we're going to have to get you some additional, we'll tell you how it's going to work, but who's going to do it and all that, we'll be letting you know probably as we get a little closer, but those are some of the big things that I know we're working. But the big thing we're here to talk about today is community care. And how we're going to work, we're shutting down that Choice Act. Choice will be done as of June 6th, so choice will be a word that you need to take out of your vocabulary and kind of throw in the trash can like we are going to do here at the VA, and it will be community care. So community care is kind of the word you'll want to put in your vocabulary, so VA community care, and that's Cheryl and her team, and that's what we're going to talk about today is kind of how that's going to work and go from there. So I'm going to let Cheryl brief, and then I'll let Dr. Kamanduri kind of fill in some additional things from the clinician side on that as well, and then we will kind of open up and we'll do a Q&A, and like I said, we're going to do it kind of, since we're recording this and we want to capture this information on video for our other veterans and family members who might be out there, please wait till the mic comes to you before you ask your question today. So Cheryl, I'm going to turn over to you here in a second, but I see Dr. Strawn is in the back too. So Dr. Jennifer Strawn is our Associate Director for Patient Care Services. She's also our nurse executive. So Dr. Strawn, thanks for joining us today as well. So, and then we also, I know, thank you for all of our veterans and family members and caregivers that are here. We also have some of our key staff that'll be implementing this Mission Act here today too. So I would like to thank our VA employees who've taken the time out of their schedule to join us today as well. I know some of you have actually come in on your time off, so thank you for doing that. This is real important. So Cheryl, let me turn it over to you and let you get started.
Okay. All right, thank you. Okay, behind me are my slides. All right, so initially, okay. All right, so in regard to the Mission Act and community care, initially for the veterans would be access to urgent care, and I'll get into more of that. Expanded eligibility, and I'll talk about that next. Scheduling the veterans at the VA, in other words, the VA is going to be taking over the scheduling. So, and that'll probably be about 60 days. So you won't have to call TriWest, you'll be calling us and we will help you expedite it. So it should be a lot quicker to get out to the community. And then of course there's technology that's coming our way as well. In regard to the providers in the community, the network, and that's the new term, instead of TriWest or Choice, it's the network. They will actually do the credentialing of all the providers in the community and the hospitals that we send patients to. There'll also be mandatory training for them, and there's going to be a 120-day turnaround time for claims to be paid, so that we'll get our medical records back a lot quicker. And then for us, the staff, it'll be streamlined much, much better, and that'll allow us to be more efficient, which will allow us to help the veterans get out to the community a lot quicker. So in regard to some of the eligibility, there's basically 6. Best medical interest, I'll talk about in 1 second. That's on the next slide. Obviously, services we don't offer is still on part of the eligibility. Lack of full medical facility, which we have medical facility. The Choice 40, they're going to grandfather in patients who were Choice 40 eligible on June 5th, 2018. So if you were eligible for Choice 40 on that date, you'll be grandfathered in for 1 year. And the VA will help expedite the services that are needed, for those veterans. Care or services not provided, I just talked about. Required care or services not offered. Grandfathered. Okay, let me go there. Okay, there's also tools that we're going to have available to us that'll help show the physician and the veteran together the eligibility that they can have, and also the services, how long is it going to take to get to a particular service. And I have that on another slide. Okay, best medical interest. I just want to make sure I tell everybody everything. Okay, so for the best medical interest, the veteran will come in, say to their primary care physician, they'll sit down and have a conversation in regard to where is that veteran best served for the need. If, say, they need orthopedics, cardiology, that discussion will take place, and for the veteran, where is it best, community or here? Hopefully, the veteran will choose VA. If we have that service. Otherwise, they will have the option to go out to the community for that service. Okay, I think, all right, that might make it quicker. So access standards, this is a new one. For primary care and mental health, if we cannot get you in a 20-day time frame, you will be eligible to go out to the community. If we cannot get you in a 28-day time frame for specialty clinics, you will be eligible to go to the community. There's also drive times. If it takes somebody from their home to, say, primary care or mental health, takes them longer than 30 minutes to drive, then they're eligible to go to the community. If it takes them longer than 60 minutes from their home to the specialty, which is here at this VA, longer than 60 minutes, you'll be eligible to go out for that service as well. And that'll be determined at the time of the scheduling. And then the grandfathered piece I spoke about briefly is good for 1 year till 2020. I don't know right now what's going to happen in 2020, but all those veterans who were eligible, again, on June 5th, 2018, will be eligible to keep that benefit. And again, it'll all be run out of the VA versus Tri-West, because that's how it's been done up to this point. Then the urgent care benefit. For urgent care, and we will let everybody know as soon as we know which agencies are going to fall into that, because it has to be in the network. So if a veteran needs to go to urgent care, you got to make sure that that urgent care agency or vendor is in the network. The veteran can go up to 3 times without having to pay a copay. After the 3rd time, it is 30 days. However, it goes by your priority group. And I believe that's on my slide, yeah. So if you're a priority group 7, 8, then you would pay $30 every time. Groups 1 through 5, it just depends. If it's service connected, you'll pay after the 3rd visit. And then the next slide, this is the decision support tool that I briefly mentioned. When the veteran and the physician are sitting together, the provider can bring up this tool, and it will actually show us the eligibility in regard to time and in regard to the number of days, and also the eligibility, what they're entitled to. Over here on the right-hand side, where it says community care, grandfathered, best medical interest, that shows the eligibility. Over on this side, it shows if they're eligible for urgent care. So we would know immediately what that veteran who's sitting in front of us is eligible for. The other thing with this tool is other staff can bring it up. If, say, a veteran calls and wants to know what their eligibility is, we can actually bring the tool up and it'll show us. So it'll be a lot quicker getting answers to the questions that a lot of veterans are having. And that's just a very brief overview in regard to the community care. Okay, urgent care. If, say, you broke your finger, you could go to urgent care. You have a bad cold, don't feel good, you can go to urgent care. What you don't want to go to urgent care for is to replace your primary care physician. That is not what urgent care is for. And also, you don't want to go to urgent care for chronic illness. You need to maintain seeing your primary care physician for chronic illnesses, and hopefully the veterans won't use urgent care as primary care. The other thing is you don't need the VA to approve you to go to urgent care. So after June 6th, and again, once we know who's in the network, you can go without notifying the VA to urgent care.
Right, but the important thing is that you have to be an enrolled veteran and you have to have been cared for by the VA within the last 2 years. Just because you're a veteran doesn't mean you go out to urgent care and get the benefit. You have to be enrolled in VA healthcare and have been seen by us within the last 24 months to qualify for that. And those visits, the payments and that's a calendar year thing. So pretty much everybody is in a different priority group based on their level of care they provide. Pretty much after 3 visits, everybody's going to get a $30 copay. And then based on your priority group is depending, like priority group 7 and 8, you automatically get a $30 copay. Priority 6, you get a copay if it is a non-service connected item that you're going out for. But priorities 1 through 5, those are free for those first 3 visits.
Yes.
So,
Go ahead. Microphone. Yes.
yeah, can we, yeah, let me, yeah, once again, please wait till the microphone comes to you for questions.
The decision support tool, is that going to determine what priority group you're in for urgent care? Or how do we find out?
Yeah, it's your service connection.
So your priority group is determined when you enroll for VA healthcare. So it depends on if you're service connected or not, if you're non-service connected, whether or not you're subject to co-payments, or if you get a VA pension or any other kind of benefit. So normally when you enroll, the Health Eligibility Center from Atlanta, Georgia will send you a letter welcoming you to the VA and telling you what your priority group is. If you don't know what it is, you can check with our enrollment department here or at any of the PCCs and they can tell you what it is.
Great. Thank you, Laura. All right, so I'm going to kind of fill the gaps on a couple questions here, and then we'll open it up to the audience. So,
I have a question. If you have a chronic disease like asthma or something, can you go to an urgent care if you need a steroid shot or you need a nebulizer treatment or something like that instead of going to the ED?
You can, but I would be very careful because if you have asthma that bad, you might want to go to the ER, depending on how bad your breathing is. Also, you would want to make sure that you do maintain contact with your primary care physician so that you make sure you're on the right medication for that asthma. But yes, you can. I would just caution you to be very careful, and the urgent care would probably tell you too you need to go to the ED if you were that bad.
Thank you.
all right, thank you. So I want to get through a few important questions here before we open up to the audience, and these are some of the things that are in the brochure, and this is really, I think these are important things that people should understand here. So basically, like we said, the urgent care, you have to have been met here in the past couple of years, but for the community care, obviously we talked about the important things here that the VA will schedule your community care appointments, so that will be not the third party anymore. So that was another important thing I wanted to bring up. The other question we get is co-pays. So people have asked, hey, am I going to be charged a copay if I go out for that community care? And the answer, I think, is based on if you're charged a copay or not within the VA currently.
That's correct. That's correct.
Okay. So that's the other thing. So Leo asked a very good question there about how you find out about your eligibility, and eligibility will tell you what if you're titled, if you have to pay copays or if you have to pay copays for pharmacy items, things such as that. So that's a very good question. So that'll answer that question if you go out too. Next question here is kind of about beneficiary travel. Are veterans eligible for beneficiary travel if they go out to the community care?
There's been no change in the regulation for that.
So if they're entitled now for beneficiary travel, they can
They
go out and use it.
continue.
Excellent. Okay. And then the other thing was on here is that will I be charged a fee for a no-show for the community provider? Yes, and that is on here. It says if the community provider charges a no-show fee as part of their practice, you will be required to pay that fee as part of to the community care provider. Okay, and we talked about that one. Just trying to cover some of these things that are probably really good here. And then the other thing is it asks, will I be able to go to any community provider I want? How does that work, Cheryl?
Well, actually, the veteran does have a choice. What will happen is you call us, say you have to go see an orthopedic doctor. We'll pull up those physicians that are closest to you by your zip code, and you tell us who you want to go see. Now, there are preferred providers, so if you have a conversation with your primary care doctor and they're recommending somebody, we can try to get you to that. But the bottom line is the veteran has a choice to select who they would like to see. Again, we all hope that they choose the VA.
And the important thing is the provider has to be part of the network that's been set up. One of the things that you will find, there are providers that won't join a network. So we can't send you to somebody that says, I'm not going to join the network. So that is a possible. There's hospital systems that won't join the network. So a good example, a system that historically, and they may change right now, but used to be MD Anderson, great cancer center in Houston, great place, didn't join networks. Now, that's a different issue. So you can't just go to a place like that if they're not part of the network.
And we would be able to tell you if the provider that you might want to see is in network. And we can also try to get that provider to join the network. But it might, that does take some time.
All right, so before we go over, I'm going to open it up to the floor to questions here in a second. Before I do that, though, Dr. Comer, did you have anything else you'd like to add?
I think the thing you're going to hear more and more from our end is really to say, get veterans to choose VA, right? We want veterans to stay with the VA, the coordinated healthcare system it's the largest integrated healthcare system in the world. So we know this is a system that works well together, gets the care together. So we want the veterans to choose VA. Now, the challenges we find in a community like this, if I tell you I can't get you into primary care in 20 days, it is hard to find primary care in town that will see you in 20 days. If you can find one, please let me know. I'm looking for one actually for myself, but you can't find one in primary care, right, in 20 days. Very difficult. Most of my primary care folks I know in town are booked months in advance. So that's still a possibility. If we don't have access in 20 days, we don't have a specialty care access in 28 days. You say, oh, the VA specialist is available in 35 days, so now you can go leave the VA. So you leave the VA. The community provider might not have access to 60 or 90 days. You could still choose to wait 2 or 3 months in the community, even if the wait time is the VA is only 35 days. So a veteran can make that choice, say, no, I'd rather wait 3 months to see an outside doctor instead of seeing a VA doctor in 35 days. So, but still, it'll be up to the veteran to make. So it does offer many more opportunities for the veterans to choose, which is the good thing, that's the best part, is the veterans will have choices and more opportunities to see things. From our end, what we need to do, if you look at that decision support tool, that we have to be able to use that, and I would ask you to be patient with your healthcare providers because they're learning to use this tool, because you're supposed to have this discussion when you come into your healthcare provider, say, how do I make this decision? What's available? If a veteran says, I don't want to go to the community, then we look for ways to get the care in the VA system. So that's going to take a little time, and we're practicing every day with our clinicians make sure they learn how to use this tool so that the veteran and the clinician together make those decisions.
Right, and I think that's an important thing. And what we're trying to do is you'll hear a lot of terms, especially in a national literature, about you and your provider will have the conversation about decision support tool. But we know the provider's time with you is important. So the other part of what we're trying to do is make sure that our nursing teams and our frontline support assistants are all kind of trained in that too, so we can kind of help you determine that eligibility. So that takes a little less time away from your appointment and the time that we have booked for you. The other thing to point out too, I think we looked at like how many people in our area would be affected by either the drive time or the wait times that are established veterans with care here. And I think it's like 96 or 97% are not going to be eligible for the primary care or mental health because of the the drive times or the and this is established patients or the wait times. We are within those things for that. Specialty care, depending on specialty care, there could be some things there, but primary care or mental health, we're definitely going to probably keep you in house for the most part, unless you're one of those 40 milers and you have a distance issue in that. So, so those are some of the things that are of importance.
One other thing, Chuck, if you can mention a little bit about how prosthetics items and things like that would work if somebody goes out in the community. I don't know, Deb, if you want to answer that question, you probably know more than us when it comes under the Mission Act.
We don't have an answer yet. Cheryl and I are still working on it. I know this morning at 10 o'clock at the national level, prosthetics, and Cheryl's whole group, along with the secretary, are having a meeting on how we can continue to not only provide all the items that are required, but how can we streamline it so that it's faster. Right now, we've had a lot of drawbacks. Where does the prescription go? How does it work? What does that mean? And so they've been meeting. Today is the 15th meeting that they met at the national level to find out how they can combine the prosthetic side with the community care side. So we're hoping in the next couple of days we'll have more information.
Yeah, and so that's the thing. People have asked us, if you go out into the community, your outside provider says, you need this prosthetic item. How does that work? And so VA is still trying to figure out how to arrange that.
All right, great. That's a good question. So I think those were the big items we wanted to hit as far as highlights here. So what we'll probably do is we'll open it up to the floor for questions. So Gabe, if you can take the mic out to anybody, and I think a gentleman over here has his hand up first.
My name is Bill Simonton. I'm the site manager for the Northeast Clinic. I'm also a veteran. I have two questions. We discussed the wait times. They said 20 days for primary care. Well, is that for established patients or for new patients? Because the new patients have 30 days, according to the present guidelines now, to get them in within 30 days. Established patients have considerably less. And the other question, the travel time. The travel. If it's not changing, where will it originate from? From the patient's home to the VA or from the patient's home to the clinic they want to go to?
For the drive times, is from the patient's home to the clinic that primary care doctor is at,
Okay,
or their mental health provider is at, the nearest.
so that won't change?
Right.
Okay.
And the other is new patients.
New patients, so it's going down from 30 days to 20 days now?
Yes.
Ooh, okay, thank you.
Welcome.
Yes, ma'am. We'll bring the microphone over to you.
Hi, Cheryl Riley from Patient Safety. Question about out in Pahrump, we have a clinic, and our patients come there, and suppose they fall, hurt their hip, and the provider deems that they need an x-ray, which cannot be done at that clinic. Does this program affect how we can order an x-ray for them? Because right now they were sent to the ED and got all kinds of tests that weren't needed, and and not the particular hip x-ray that was needed. So how would
Well,
that
I would
work?
hope that the process is not going to change. If a patient needs an x-ray up in the Pahrump area, all they have to do is call us, and then we can put the auth through for that x-ray, and it can be expedited very, very quickly.
Like within the same day?
Oh, yes.
Okay, thank you.
And we can't also, the other thing is, we can't control necessarily what the local ED in Pahrump orders, so sometimes they may order, like you said, more tests for whatever reason, but we don't have control over what the local ED there orders, yeah.
Hi, my name is Elaine Dennis, and I am the utilization manager for psych. My question is, the rehabilitation inpatient for substance abuse, will this choice, this Mission Act cover us sending patients out into the community for rehab, you know, instead of sending them to White City
Well,
or Prescott?
We do have to use a hierarchy of care, so we would look there first. If we could not get them in, then there's the potential that we could send them out. However, we're going to have our own unit here very shortly, so that'll be a great help.
But for now, we just use Oregon and Prescott
Correct.
the way we've been doing it.
Right.
Okay, thank you.
Welcome. So we have it here.
I have a couple of questions. First one is the providers in the community, will they be provided with any training related to like war-related illness? I think that's important so that when veterans are making decision to go out to community, they can understand that there can possibly be a gap there if they're not going to be receiving any of that training.
There is training that the providers in the community must take within, I believe it's 180 days after they sign up with a network. I don't have a list of what the training is. I believe it is, it definitely is along those lines.
And then my second question is about the pharmacy. Any information about how pharmacy will work if providers in the community are ordering medications for our veterans?
That's not going to change to my knowledge. I know there is some talk about standing up a community pharmacy, but for now they'll have to bring their prescriptions here like they do and get them filled.
And then my last one was just same, kind of along the same lines about requesting that Benny travel. If they're going to out into the community, do they have to make a trip here to request that reimbursement?
Laura's best to answer that one.
So in order to get travel, if they go out to the community, they do have to provide proof that they've completed a visit out there, and they can mail it in. If they want to mail it in, they don't have to physically go to a clinic, but they can also drop it off at any of our clinics. They can process travel claims there. Yes, there is a mandated 30-day time frame that you have to submit your claim from the date that you want to make, that you have your appointment, and that does not change.
Hi, I'm Janice Muhammad. I have a question about the pharmacy. So previously, patients could go, if they needed like an urgent prescription fill in the community, and they can get a limited supply. Is that changing?
That remains the same. The veteran can go and get a 14-day supply filled in the community. They will have to pay for it and then bring the bill here and they'll be reimbursed.
Okay, and then going forward, physicians and providers in the network, will there be some type of agreement between our pharmacy and the network so that community providers can send the prescriptions through and they are already, I guess, credentialed through the database, whatever, so that they can write prescriptions and be filled directly through the VA here?
Yes. We're currently trying to get some of the providers into our system so that when the veteran comes here, the provider that they just saw is in the system and it can be easily filled. Where we run into some problems are when residents or fellows write the prescriptions. So we need it on the actual prescription pad of that physician.
Yeah, I just want to say that other thing is, one of the component of this agreement, if you sign up as a VA provider, you're supposed to use the VA formulary. The challenge is a lot of the folks don't necessarily follow the formulary. That's why, people ask, why do we have to rewrite the meds? Well, we have to constantly rewrite meds in our ER or other places because the community provider is not following the VA protocols of what's on the formulary.
A couple of questions. Charles, you mentioned initially that although no one has to be with TriWest any longer, but it's still a contractor of record. Can you kind of describe what that means, really?
Right now, we don't know who has won the bid for the network, okay? So we're using TriWest. TriWest will transition for one more year. That's the modification. Say another company wins the bid, so that TriWest would be used as a transition while the new company sets up the network.
I understand, thank you. And then on the decision support tool slide that you had, down at the bottom it said if that wasn't working by June 6th, the alternatives were CPRS and PPMS. Can you define what those are?
Yes, PPMS is a tool that we use to see what providers are in the network. It's a provider, PPMS is the provider management system. And CPRS is our medical records.
And one last question. Those who do pay for their health care and then they come in for reimbursement, assuming they're eligible, do they get paid on the spot or do they get a check in the mail?
I'm not sure about that one.
Well, I think Chuck, you're confused. They're not going to pay for their medical care. If they have to pay a copay, the VA will send them a bill for a copay. The VA will send them a bill for that copay. So if you're in a priority group where you have to make a copay based on getting care from the VA, either we send it from in-house care or community care, the VA will bill you for that copay. You're not going to pay the provider, I think. Is that correct, Cheryl?
And to answer the other question, say it's the medication that they need to be reimbursed for, that 14 days, I'm 95% sure that it'll actually, they bring it in and then we will send them the check. They're not going to get reimbursed right there.
Okay, thank you.
Hello, I'm the lead medical support assistant for the dental clinic. Does the Mission Act include dental services?
It does. Right now, we're going to be using veteran care agreements, which I didn't talk about, but once a network is set up, they are going to be setting up an entire dental network.
Thank you.
Welcome. No, it has not.
All right. Next question. All right.
If a veteran chooses a outside primary provider, will the provider on the economy have something similar to My Healthy Vet, where they can do secure messaging with that provider?
Some of them do, some of them don't. However, we're going to have our health referral management system that's supposed to be implemented here the end of June. That is a portal that the providers in the community can exchange records with us and messages. So some have it, some will use what's called Virtue Pro. That's an email that they can email to the veteran a secure message. There's also some other tools that we don't have that they have, but it's individual. It's by provider.
Thank you. I'm trying to figure out the best way to word this. So if a veteran has had a conflict with a specialist, like a mental health specialist, or some of the specialists are limited, like there's only 2 or 3 endocrinologists, and there's a conflict and it's been sent up to patient advocate, will a veteran have the opportunity to choose the VA Mission Act to go outside of that due to a conflict in care?
They would. However, if there's 2 providers, you might want to see the other provider before you choose to go out to the community.
No, I'm
but
saying
yes,
if that's the
you
issue,
could.
if it's exceeded that and they've sent it up. Okay,
Yes.
thank you.
I think probably just to clarify on that, though, it's like if we have the care in-house and that eligibility, I think we send them to our in-house provider if we have the care and all that first, yeah, and then if that's, yeah, okay. All right.
Hi, this is Patty Toomey, the OR PACU manager. I was wondering if there are any separate marketing strategies that we're going to be implementing to attract those who are, say, coming in for surgery and they live in Pahrump more than 60 minutes away, where they could go to the an outside provider. Is there a way to market as to us why they should come to see us? Maybe partner with local hotels for a discount where they could stay in town instead of having to drive all the way back. I didn't know if that was in the plans.
I think that's an interesting concept. So as far as marketing, no, this is all being driven from the top down. So we get like 50 emails a day on marketing materials. So we put out a very small handful of the very different things we have out there. So the Secretary is committed to making sure that this happens and that we provide veterans with the best choices and the best options and the best information possible. So they are overloading us with materials, which is good, which is a good thing. And what we try to do today here is our local Las Vegas team is trying to give you this, make sure you take this one pamphlet. If you take anything today, take this. It does kind of have all that information. But as we continue to move on from the national level on down, this is a priority of the Secretary. He just added customer service to our priorities as a core competency for the VA. So this is being driven from the top down to communicate as openly as we can about the options that are available and you know, why you want to continue to come out. But a lot of that will be, a lot of that is going to be one-on-one conversations between our VA staff members and the veterans. So a lot of that is going to be incumbent upon our VA staff members. And we've sent all of our VA staff members, most of them, to training as well about the VA Mission Act so that they can talk about it, because we all have to be advocates about the Mission Act. Because if we can't explain to the veterans what the Mission Act is and what their options are and why it's good and here's how you know why you should continue to choose VA, then you know we can't expect the veterans to make a fully informed decision. So we all have to be advocates as VA employees as well. But we will continue to share the marketing materials. We are standing up some websites nationally. I know we'll link to those sites because we want you, and a lot of you in here are community stakeholders too. Work with the media, or you work with various support groups and that too. So we ask for your assistance as well as helping us get the news and information out as we get it as well. So we want our veterans to know that they're empowered and that we want them to make informed decisions with that empowerment as well.
Just to say that I would say there's 3 reasons to choose VA, 3 things that the VA is better than the private sector, okay? If you look at major journals, New England Journal of Medicine, American Medical Association, all of them will have come out with multiple studies showing the quality of care in the VA is better than the private sector. There is no doubt the quality is better in the VA system. That's one. Second, that's important, is this. Access. You know, you have this 20 and 28-day standard. That was set. How many outside facilities, hospitals, clinics publish their access standards? Do they give you a number when they're next available for a brand new patient to see? There isn't other systems, because they realize it's not easy to do. They know the access is generally not that great. And so our access is better. So our quality is better, access is better. The third thing that doesn't get mentioned, VA is a transparent organization, which is not necessarily true of all healthcare systems, right? VA is completely open to disclosure. If something goes wrong, the VA sits down with you and tells you, hey, this is not expected, meeting our standards, what we want. We're going to give you the opportunity and let you know, honestly, tell you what happens. Not all, some hospital systems do this, but many hospital systems don't do it. So those are 3 really important reasons that I think we need to let our veterans know, that the reasons to choose VA. I mean, number 1, veterans should have choice. As we all agree, they should have a choice. But as our executive in charge, Dr. Stone, says, look, veterans will learn when they go outside that the choices are not that great out there either. They'll come back, and most of our veterans, as Dr. Stone has said, will want to come and stay with the VA because they'll realize it is better in the system.
And I think that's important too. Thanks, Dr. Comanduri. And I think our thing here at the VA is we try to stay out of the politics. We try to stay out of the, you know, there's lots of organizations and individuals out there with agendas. We try to stay out of that. Our job is to implement the laws as Congress has written them and provide our veterans with the best care and services possible. And what we'll do is we're going to do everything we can to make sure that they're informed and educated to make those decisions. So I think we have time for like 1 or 2 more questions. Bill, did you have another question, sir?
Yeah, this is more focused with primary care. As for when you send someone out, they have a choice to go out to the community, correct? We always establish that. Now, unlike specialty, with primary care, it's pretty much the issue that I've talked to a lot of providers is the conflict. How long will they be staying out? If they chose to go on the outside, how long will they be forced to stay out until they come back into the primary care? Because
Well, they're not forced to stay out. If they want to come, if say they go out and see a primary care doctor and they're not happy and they want to come back to the VA, they certainly can do that. There are 6 months and 1 year episodes of care that we can offer that veteran. Yeah.
Okay, that's what I was thinking about as far as the episodes of care, because I've seen veterans that go out and they'll get a script written out that the VA doctor said they didn't need, and vice versa. It was a conflict of interest with primary care. And I was just wondering if that's been rectified. I know at one point it was a year. If you chose to go on the outside with primary care, I don't say you forced to stay out there, but that was the.
Yeah, they can always come back.
Okay. But that's not a problem with the conflict of care as far as the.
Now, if they come back, they need to stay here because where you have your problems is when you have two of the same two primary care doctors, taking care of a patient. That's not good anywhere.
That was the point I was making.
Yeah.
Thank you.
We're certainly in our infancy stages of this, but we're excited about it. The eligibility criteria is 6 here, but of course, there's going to be different scenarios, things that come up. Who's going to make that determination? Will it be the network or the provider?
For the eligibility, it actually comes from the enrollment system. So that's where, although it's not up there any longer, the tool that I was showing what the eligibility was, that's where it comes from. So it's all based on the information that's been provided to the enrollment system by the veteran.
Right. So it's really important to keep your information updated, like your address and all that too, because a lot of this is going to be based on your location. Like they're going to determine your driving distance and your eligibility on those different programs based on your current address. So it's very important to keep your information updated with the VA so we're making correct determinations.
I have a question. I'm from the Southeast Clinic, one of the providers. Basically what it is yes, we know what our desire is and what our goal is. Have we had a chance wherein there is a feedback wherein the patients that we sent out to the community for whatever they need had come back to you and they really have waited more than 30 days? I have had patients like that. So how shall we ensure that when we send our patients to them, it's on a timely manner that they'll be seen? They're choosing that community or that provider outside because they think they'll be seen in 30 days. But I have had patients that are waiting until July.
Right. It depends on the service. The access may be longer than the time frame that they could be seen here. It depends on the service. Primary care, I know there's a 3-month wait. Some specialties, it could be 60 to 90 days before they can get in. It just depends on what service they're looking for. And we would tell them that, so then they can make a decision to come back instead of going out to the community.
And VA is actually working to get the data, and there isn't good granular data on this area. And some regions of the country actually have really good data, not necessarily out west as much, more on the East Coast, but at any rate, not especially in our state like this, in a large area. But what you have is really good data on what is the true access in the local community. And then you can give the veteran, say, this is what it is, and you can choose. If a veteran says, look, I really, really want to see this person, then that's great. But as long as you're willing to wait for that, and you and the veteran can, as a clinician, can agree that it's okay to wait that long, then it's doable.
And I just wanted to say that's one of the great things about the Mission Act and putting the scheduling back into VA hands, because when Cheryl and her team talk to a veteran about their options, they're going to be able to explore all those options with them and kind of let them know what they're looking at in the community versus the VA. Maybe we can't make that 28-day deadline for a specialist, but maybe we've got it in 30 or 35 days like Dr. Comandori was talking about earlier. So Cheryl and her team will be able to go, well, here are your options. These community providers are X amount of days, the VA is X amount of days. They'll work with that veteran for him or her to make the best informed decision they want on where they want to receive that care since they meet the eligibility. And the other thing I would like to point out to you, we're going to wrap up here, is on the back of this flyer we gave you, it says additional information. And the things I wanted to point out on there, one, there's a website on there for the Mission Act, so it explains it in detail, the kind of the program. And if you have any questions nationally, that number's on there as well. The second thing on here is called accesstocare.va.gov, and that will show you kind of what our facility wait times are. It also shows you some of our other quality data, and some of that other information on there. Once we stand up the urgent care benefit, I think some of that stuff will be on there as well. But that is a real good source to look at, and I think they will start putting some of those community wait times on there as they start getting some more of that information, as Dr. Comanduri said. So that's a good one on there. And then as we build up the urgent care benefit, there's there will be on our va.gov site, that site has been totally revamped to be more user-friendly for our veterans. You'll be able to kind of go in there, and once they establish and we know who those community care providers on there will be a map on that site that shows where all our in-care urgent network locations are. So you as a veteran will know if you need to go get that urgent need taken care of, you can do that. And then also just wanted to point out, as far as urgent needs, we do have same-day services for veterans for mental health and primary care for urgent needs at all of our sites of care during regular business hours. That's our 4 PCCs on every corner of Las Vegas Valley, as well as our Laughlin Clinic, our Pahrump Clinic, and here at the medical center. So those, and then after hours, we do still have our emergency department for emergent needs as well. So those are some of the options. So we wanted to thank you for coming out today. Like we said, we do have other materials in the back, but the big important thing to take with you today is this this pamphlet with you, because I think that has some of the big questions, and it also has some of those other sites to get resources. So want to thank you for spending some time with us today. We'll stay here for a couple more minutes if you want to come up and ask us any personal one-on-one type things, but we do appreciate you turning out today, and have a great day. Thank you.